Okay, well, I'm going to go ahead and get started, and you should be able to see the PowerPoint presentation. And I've just got to move one other thing around on my screen so I can see what is going on myself. It's always helpful. All right, good. I had a few more people joining, so let me see how many we've got there. Perfect. All right. Well, I'm going to go ahead and get started. I'll just introduce myself real quick. My name's Vince Lepak. I teach for Therapy Ed. I'm one of their instructors. I'm also a professor at the University of Oklahoma, and that's my full-time job. I've been teaching licensure preparation for it's maybe 25 years, something like that, 24, somewhere in that region. And at any point, if you have a question, please put it in the chat or open up your mic and please ask a question. I will always try to look at the chat. There may be times when it takes me a minute to get to the question, but I'll get back to it. So I'm going to talk to you a little bit about electrotherapeutics. It is not a big section of the exam, but of course, what do we want to do? We want to get everything correct that we can. And you don't expect a lot of questions in terms of therapeutic modalities on the NPTE. What's really important is you need to understand the application, the indications, the contraindications, and precautions. And what we're going to concentrate on tonight is electrotherapy and iontophoresis. And so that's where we will spend our time. A couple things, like you see some of the other modalities listed in there. Understand that phonophoresis is not something you really should spend time on when preparing for the exam because that has received such a low level of importance. Somebody asked, when will this online office hours be posted? I don't have the answer to that. I'm sure they will. They have not told me that, so I'm sure they usually post it pretty quick, but I'm not sure of the exact time frame. So I'm going to start out with a question. I'm going to let you read it for a minute. While you're reading it, just kind of make your best choice. And I'll just start to read it while you kind of finish up and thinking about it. Of course, you would have more time on the real exam, but we are limited in our time tonight. So you've got a physical therapist provides treatment for a patient who's 2 weeks status post anterior cruciate ligament repair. The therapist decides to promote quadricep strength since the patient is unable to volitionally achieve the last 20 degrees of their full passive knee extension. Which of the following is best to increase knee extension strength? And so this could be one way that you could see the application of a modality, especially when we're talking about electrical stimulation. So one of the things you should not do is do biofeedback for targeting the vastus medialis. So there's really no evidence for that. And of course, if you're thinking about what is their impairment is being able to activate their quadriceps in that last 20 degrees. And continuous passive motion, of course, would not do that. So then you're looking at NMES, neuromuscular electrical stimulation, and transcutaneous electrical stimulation. So transcutaneous electrical stimulation is really designed more for pain. And it's at a strong sensory level. So there are methods with TENS that you could do a motor level, and you could maybe argue that, well, can't you use TENS? But not at a sensory level. What you need is neuromuscular electrical stimulation. And so one of the things that comes up and why this is important, you may not realize it, or you may realize it, part of our clinical practice guidelines for knee ligament sprains is that there's a grade A level of recommendation for the use of E-stim for strengthening, for increasing short-term function and strengthening. And that's important because one of the things you'll see are those kind of clinical practice guidelines and those levels of recommendation weaved into it. And that could also be with modalities. And it really does make a big difference, especially in those individuals who have limited ability to activate those quadriceps strength. Any questions on that or thoughts? All right, well, I have one more question, and then we're going to get into the meat of everything. Perfect. I'll start to read this one. You got a physical therapist who provides treatment for a patient who has chronic neck pain and with radiating pain to their elbow due to lateral stenosis. The therapist is unable to centralize their symptoms with should be in there, cervical mobility exercises, and decides to use a modality in combination with cervical stretching and thoracic mobilization. Which of the following interventions has the highest level of evidence for this situation? And again, so one of the things that's going on is you're thinking about neck pain with radiating. And so that makes you think about, well, what am I supposed to be doing with those individuals? And one of the things you're supposed to be doing is stretching along with thoracic mobilization. So those are important thing, as well as cervical mobilization. Now, biofeedback is not going to help with that. And so that would be used for reducing muscle activity, but that's not part of the clinical practice guidelines. And low-level laser is suggested for some other conditions, but not cervical radiculopathy. And then the other thing that's not recommended is TENS. So this is actually going to be traction. Now, I know this is, electrotherapeutics, but one important part is knowing not only when to use it, but also when not to use it. All right, so it is not recommended for this, but actually traction is, and it's intermittent traction. So one of the things that's recommended with our neck pain, with radiating pain, is the use of stretching and thoracic mobilization, along with traction, intermittent traction. But it shouldn't be just used alone. So again, what I've tried to do is present a couple problems. One where you clearly know, trying to think about which electrotherapeutic modality to use, and also when, the second question is when not to use them. All right, so now I'm going to get into the crux of what I'd like to talk to you about. And you should understand electrical stimulation, not everything. Again, it won't be, let me check here. So I'll go back. So somebody asked the question about traction. It's not contraindicated. Is it chronic? So traction, so it's a great point. With neck pain, with radiating pain, traction is indicated along with other things, and they recommend intermittent. And there's a good, a grade B level of evidence, so that's really good. Now with low back pain, all right, that is, if you're dealing with low back pain, then there's contradictory evidence. So there is contradictory evidence with low back pain. And so I'm glad somebody brought that up in the chat, because it depends sometimes if you're talking about neck pain or you're talking about back pain, what's recommended. So great point, and I appreciate you bringing that up. So let's talk about electrical stimulation. And I like to group it into kind of these three big categories. So we can talk about pain management, we can talk about muscle dysfunction, and we can talk about tissue repair. So those are the primary things we use electrical stimulation for. And I'm going to start in with your contraindications and your precautions, because this exam is about safety. And so you're going to see a lot of safety questions. I don't care if you're talking about any type of modality, any type of manual mobilization. You always have to make sure your contraindications and precautions, there are none, because you're going to, again, this is an exam and a large portion of it is devoted to safety. So again, contraindications would be a demand cardiac pacemaker, a defibrillator, or unstable arrhythmias. And what they mean by that is the current would go through or near those devices. All right, so if you had somebody with lateral elbow pain, could you still use electrical stimulation or even ultrasound? Well, yes, but you wouldn't want to use it up near their heart where the pacemaker might be, something to that effect. And so, of course, you wouldn't want to place electrodes over the carotid sinuses, because that could drop your blood pressure potentially. And if you think there is some type of DVT or something to that effect, it's probably not a good idea to do a lot of stimulation over that. And pregnancy is not a contraindication in and of itself. It just means that you don't want to run the current through the baby. All right, so that's what you don't want to do, is you don't want to run the current through the baby. So could you use it on the arm, the shoulder, the hip? Yes. All right. You're just trying to prevent running it through the baby. And then we always have to take precautions with people who have cardiac disease, if there's impaired mentation, because they may not understand what's going on. If there's impaired sensation, we always have to be more cautious, because they may not feel the normal responses that you would expect. You shouldn't probably be stimulating malignant tumors. And then you have to be careful if there are open wounds, unless you're applying it for the purpose of tissue healing, and we will get into that tonight. So a couple things. When we think about pain, one of the things I want us to think about is we can apply it at a sensory level, a motor level. We can also use biofeedback. Now, I'm not going to spend time tonight talking much about biofeedback. But biofeedback, in summary, is if you were using it for pain, you would be trying to shape down the muscle. So they would be paying attention to a device, looking at how much electrical activity was occurring, and then trying to consciously decrease that activity. And that's how you might use biofeedback for pain. And then you can also use iontophoresis for pain. So those are the four primary ways we look at pain. We also look at muscle dysfunction, and I'll go into these in more detail. So if they have weak muscles or something to that effect, we can try to strengthen them. We can try to decrease spasm and spasticity, although that's only temporary, and typically that's not what you're doing with it, so we won't cover that tonight. There's functional electrical stimulation, which is where you'd use E-stim as an orthosis, maybe to assist with gait, as an example, or to help them extend their wrist so they could get a better grasp. Because as you extend your wrist, you increase the length of the finger flexors, which would allow a little bit more grasp. And then you can also use it for facilitation or re-education. So maybe it's not a true strength problem, but maybe what you're trying to do is facilitate the muscles, because they may be unable to activate it. It's like if you had somebody with a lot of knee effusion, they may not have a true loss of strength, but they just may be able to activate those muscles. And so you just may need to facilitate them. And then it can be used for range of motion, but ineffectively. So there's not good evidence for using it in people who have a coma and other things of that nature to really change their range of motion. The other thing, and I know this is a busy slide, is that we can also use it for tissue repair. And so there's a variety of different ways. We're not going to get into several of these, but I will briefly speak about them, but I'll spend more of the time in some other places. So you're going to hear what's called high volt pulsed current. And a lot of times what they mean is they're talking about a monophasic pulsed current to promote tissue repair. All right. So there's actually, you can also do it with direct current, but we'll have to get into that in a minute. And so the thought is there's an injury potential. When I scratch my skin and all of a sudden I have a wound that opens up, then there's a charge difference between the dermis and the epidermis. So your epidermis is relatively negatively charged to the dermis. But your skin has an ohm resistance of about 5 to 8,000. Again, that would not be on the NPTE, but this is just helping you understand what goes on. So when that gets cut, all of a sudden, there's actually a voltage gradient that occurs. You begin to get current flowing, and that's called the injury potential. And so your body recognizes that there's an injury there because there's a current flow detected. And then your body goes, hey, I need to heal that. And so there are certain things, certain polarities that can help with that. So with bone, I'm sure you've heard of bone stimulators before. They use current. They can use current to do that. And so usually the negative is used for that. And then epidermal healing is the positive. And then most of the time what you're doing for tissue healing is the negative over the wound. And then if a wound's infected, E-stim also can be used to decrease that infection and usually use the negative pole over that, right? So those are the two primary methods that are used for tissue repair. There's some people who propose that, by decreasing edema, using a muscle pumping action, you can use E-stim to help reduce that. And also if you can get the muscles to pump, then you can increase circulation. And when you have increased circulation to that area, then you can affect tissue healing. What we're going to spend our time on is really the high volt pulsed current and the direct current with respect to the injury potential, because that's a little bit more confusing to most people. So one of the things as we're talking about current is to understand the basic different types. And we use 3 different types of current in physical therapy. We use a direct current, and you might think about that as a battery. Your car battery is a direct current, or a battery on a little lamp that turns it on is of course direct current. And then we have alternating current. We use alternating current when we talk about differential, and we're not going to get into that. It's just a different type of current. It can be used for pain. It's used in the same way. It can be used for muscle stimulation. It's used in the same way as what we primarily use, which is a pulsed current, right? So there's pulsed current and direct current are the primary ones we use. And then we also sometimes use interferential current, which is an alternating current. And we think about that as our house current. Now, within pulsed current, we have monophasic and biphasic current, all right? And I'll go into a little bit more definition of those at some point. So this is direct current. You can see that you can think about the car battery. It's a monophasic current. It's not pulse, so it's on continuously. So one side of the circuit is positive and one side of the circuit is negative. And that can be used for wound healing. So that's pretty good. You would not want to use it for muscle stimulation, and you would not want to use it for pain relief. All right. And then there is alternating current. Sorry, that's my little dog there. He's wanting to join the conversation, and I have to stop and Sorry about this, but I'm going to have to stop and get control of the little guy. I'll show you him in just a second. Hang on just a second, because I know what he wants. This is the little guy who's causing all the hassle here. His mom's just outside, so I'm going to go give him to his mom, and then I'll be right back. Hey, guys, I'm going to let Milo on, and then I'm because apologize about that. See what's in the chat here. I might see. Oh, thanks. Yes, he can be adorable. He's I have two Shih Tzus, so they're the handful. I will tell you that. So direct current is again, we can use that with one other modality. I won't get into that at this point, but I will talk about it here in a little bit. And we can use it with wound healing. Again, alternating current is what we think about as household current, but it is also used with interferential, which can be used for pain. But most of the time, what we're using is what's called a pulsed current. So a pulsed current just means there's a unidirectional or bidirectional flow of electrons with a break in a period of time. And so it's not on constantly. And if it's monophasic, then one side of the circuit over here might be positive and the other side might be negative. And if you have a biphasic with that circuit, then you have usually a fairly balanced waveform. You don't truly have like one pole being negative and one pole being positive. So terminology is important. When you come across terms, you're not sure about them. It's important to look them up because they help you with the foundation. So pain. So pain, we can attack it with a sensory level type of stimulus, a motor level type of stimulus. Again, we can use biofeedback and iontophoresis. So you're probably familiar with TENS. So TENS is transcutaneous electrical neuromuscular stimulation, and it's usually used for pain. And so we usually think about kind of it on an intensity level, from lower intensity to higher intensity. And so the higher in the intensity means that you're going to reach, have enough charge sooner to depolarize that nerve. But once you have enough intensity to depolarize that nerve, then you're going to get a sensory signal. And if you keep turning it up, all right, to a higher intensity, then you may also get the motor level response. So most of the time what you feel is a sensory level, and that's because those the nerves, the sensory nerves, are closer to the surface of the skin, so they're easier to stimulate because of their location. Motor nerves in an anatomical or model is easier to stimulate because they're larger and myelinated, but their location is usually deeper. So it's really the location that matters. And so sensory level, again, is usually a lower intensity, and you begin to feel what you're activating are the A betas. And then that is supposed to cause a gating effect. With the motor level, you're getting the A betas because you're getting sensory, but then you're also getting the muscle to pump. And then that's supposed to release beta endorphins. And that's why exercise feels so good, is because you can release endorphins with that. And then there's what's called noxious stimulation, which is where you turn everything up until it's painful. The mechanism of that is not really known, and I'll go into that in a little bit. All right, so those are the kind of three things we usually think about with TENS. So with and part of the problem becomes the terminology. So there's different terminology out there, and again, the NPTE tries to take care of that. So sensory level TENS is also known as conventional TENS, and you may have learned it that way. But basically, the frequency you use, and usually use a higher frequency, which is 80 to 100 pulses per second. I don't know that they would ask you the exact pulses per second. I doubt they would ask you about the pulse duration, but it usually uses a little bit lower pulse duration. So I would not spend my time memorizing that. But this is usually the first choice because it's very comfortable. And we're usually using a pulsed current. All right, with this. Now, an interferential current can also be used, but usually it's a pulsed current. And when we think about using it, we try to surround the site of pain. So in terms of application, we want to surround that site of pain or some type of peripheral nerve trunk that innervates it. It can also be used on acupuncture sites, all right? And I'll get into that in a little bit. So there is evidence out there. It's a lower level of evidence, level C, in terms of its recommendation for acute and chronic neck pain and actually lateral elbow pain. But I do not want you to leave you with the impression that it should be used in singularity because these are recommended to be used in combinations with other things only as an adjunct. Okay, so only as an adjunct. You've probably seen these TENS devices. And so what you should know is that it primarily is the primary one we use. We usually use it for a quick effect, all right, to kind of decrease pain. And you're using higher pulses per second. That's why it's known as more of a high frequency sensory level. There is a way to do it low intensity, but it's usually the higher frequency. And here's an example, like if you've ever, I don't know, hit your thumb with something, you shake your hand. Why do you shake your hand like this? Ow, ow, ow. No, you shake it like this. Okay, so you shake it a lot because you're trying to activate those mechanoreceptors more often in order to cause a gating effect, a greater gating effect to block that pain from transmitting up. Same thing with the TENS. All right, so that's why you want to usually use a higher frequency for that sensory level because you're trying to get a better gating effect. Now, there's also motor level TENS, and motor level TENS is usually used with a low rate acupuncture-like TENS. So you're trying to get a visible muscle contraction. And so, again, there's a variety of frequency. That's not the important part. The important part, it's lower rate, so you get the muscle to beat. All right, you're trying to get that muscle to beat. And that's supposed to release those endogenous opiates. That's the real key there. Again, sometimes in terms of electrode placement, if it's a painful site, it may not feel great to put it on that painful site. So you use sites that innervate it, acupuncture points, something to that effect. And so sometimes this is referred to as burst TENS, something to that effect. It's also referred to kind of low frequency acupuncture-like TENS, but it does have a level C recommendation in people with lateral elbow pain. So that's one of the things that has a recommendation. And also with acute or chronic neck pain, and that's also a level C recommendation. So we have sensory level and we have motor level. Both have, their uses. One is not necessarily better than the other. They're supposed to have different mechanism of actions, but that actually still has to be worked out. And then the other thing is with motor level TENS, you can turn it to a high frequency. So all that means is you're turning it up. And one of the things that happens when you get a muscle contraction, you get tetany. So you want a nice smooth muscle contraction. We call that tetany. To do that with electrical stimulation, you need about 25 to 30 pulses per second. So 100 would be a nice tetany contraction. And so what you're doing is getting it to contract and trying to fatigue out that muscle. So again, it could be used. They don't specify if it's low level motor TENS. I'm sorry, low frequency or high frequency motor level TENS with those clinical practice guidelines. They just recommend that you could use acupuncture points for short-term pain relief. So that means one is probably not better than the other. And then one of the things you will not see kind of discussed in our clinical practice guidelines is noxious level brief intense TENS. I only mention it because you may have learned about it, but basically you're turning everything up until it's painful. All right. So this is, of course, not usually our first choice, and the mechanism of action is unknown. There's several proposed theories on it. Yes, so noxious level is also known as brief intense TENS. Yes, absolutely. And so, that is not something I would spend my time on. It's one that's used of last resort. So electrode placement, again, usually when you're talking about TENS and you're usually looking at the site of pain, unless you're using kind of a motor level and it hurts in that area to contract those muscles, then you have to look for peripheral nerves that supply that area. You can do spinal nerve roots, all right? That's another method, or the spinal cord segment, running it straight across the spine. You can try to use related dermatomes, sclerotomes, trigger points, motor points. But the great thing about this exam, you're not going to have to memorize acupuncture points, all right? Things of that nature. So primary method that we usually try to look at is the site of pain. So now if we look at this, just take a second again. Hopefully, even though we've been talking about TENS, you would go back and think about what? Traction. That's right. So you should be thinking about traction in this situation. So going through, after you've gone through some information, it makes usually a question a whole lot easier after you've reviewed what it's for and then what it's not supposed to be also. So that's just kind of the brief review of pain and how you use electrical stimulation. Any questions before I move on? Okay, well, I'm going to talk about muscle dysfunction next, and I'm primarily going to focus on strength. All right, so that's what we're going to focus on tonight, because again, there aren't good recommendations for decreasing spasm and spasticity. Those are only temporary. Functional electrical stimulation is its whole lecture, but it's basically using neuromuscular electrical stimulation to cause a muscle contraction to help with function. And so the settings are going to be similar to what we talk about with strength. And then facilitation is similar to strength, except you're just not using as high as intensity. And then again, there's not good evidence for trying to increase range of motion or even maintain range of motion with electrical stimulation. So one of the things we can do is improve muscle performance. So there are studies out there that show changes in muscle plasticity with the use of E-stim. We can also use it to assess strength and endurance, all right? Although the protocols for endurance are not well known. And then primarily what we do is we use electrical stimulation to enhance muscle performance. And that means activation, that means strengthening, and that also means to be able to do that, we need to know the characteristics of the neuromuscular electrical machines and the protocol used for strengthening. I'm not going to really spend a lot of time on E-stim for muscle endurance and fatigue, but basically use similar protocols and you adjust on and off times, and I will tell you how to do that. So the basic goal of using NMES, neuromuscular electrical stimulation, is to activate as many motor units as possible. That's the goal. All right. And there's a lot of strength protocols out there, so we're not focusing on that. But what you've got to have is sufficient intensity. Just like if you go into the gym and I'm doing curls, 5 pounds is not going to be enough to increase strength. I need what? 70, 80 pounds in the curls, something like that, right? So that's what I need. You have to do overload, don't you? And so, and of course, we're talking single curls, but the idea is that you need sufficient intensity to be able to do that. And remember what I said is you also need tetany, and that means you need about 25 to 30 pulses per second. So about 25 to 30 pulses per second. Eliminate the word phase after that. And then pulse duration, that's set at the patient comfort. That's really what you want to remember. All right, so it should be at their comfort. And generally what's recommended is, there's not literature on every muscle in the body, so people have tested the quads, but you need at least around 60% of their maximal volitional isometric torque. All right. So of their isometric contraction, you need to be using at least 60% to get some strength changes. And then you want to minimize fatigue. So you'll see different protocols on there, and there's what's called on and off time. How long is it on? So it comes on for 10 seconds and contracts those muscles, and then it goes off for 50 seconds, and that allows them a rest time. It's just like in the gym. You do a series of contractions, and then you take a rest, and then you do another series of contractions, and you take a rest. Now, if you wanted to do more fatigue, is that you would shorten your on and off time. And if you really wanted to fatigue them out, so you could imagine 10 seconds on, 10 seconds off, and then if you really wanted to fatigue them out, it could be 50 seconds on and 10 seconds off. So that's how you would fatigue somebody out. It's basically the same protocol. And usually what's recommended is you're getting in at least 10 to 12, 10 to 15 contractions at their maximum tolerable intensity, and doing it 3 times a week if you truly want to develop strength. Now, what we know with electrical stimulation and strengthening is that there is a positive correlation between training contractions and the strength gains in people with weaknesses. And we also know that there's good levels of recommendation for people after surgery, especially ACL. I've definitely used a lot in people after total knee replacements. And you don't have to turn it up where it's so intense that it's uncomfortable for them. It should always be comfortable. But it can be a really great facilitation technique. Maybe you're not getting true strengthening, but you're facilitating those motor units to contract. And so it's really recommended even after meniscal and articular cartilage lesions if they're having difficulty contracting those quadriceps or there's a loss of function. And I might just stop right there and see if there's a question. Yeah, so somebody asked, where would you place electrical stimulation for shoulder slap for a Bankart lesion? Would you put it on the deltoid? So I guess it depends where they're at. All right. So if they have a lot of restriction and they're not allowed to do anything just immediately post-op, I'm probably not putting it on them unless they can't activate those deltoids. And again, I would have to look at the precautions of that particular surgeon and what was done, but I could place it if they weren't able to activate, let's say, deltoids, and I'm not sure that's the muscles I would exactly go for, but I would just place it over those so that the current flows through those muscles. All right. So I'm going to concentrate maybe on some isometrics initially, something like that. And they should be able to activate those. And if there are muscles that they're not able to activate, that's when I might use the E-stim. So TENS is used for pain. NMES is used for muscle strengthening or facilitation. And so that's the way you want to think about those two. So TENS is used for pain. And so let's go back to the rotator cuff repair or something like that. And they were having so much pain that they're just not able to do what they're supposed to be able to do. Well, then I would probably put a pad in, I would run the current so it would go through the shoulder and where they're having pain. So I might put one in front, one in back, and I just run current at a sensory level. So I'm not trying to get a motor contraction. And I'd use more of a high frequency pulsed current to decrease their pain. And so that's the way I would use it in that situation. Now, if I'm trying to, or let's go to somebody with a total knee replacement. They're able to activate their quads, but it's so painful. Their knee is so painful, they don't want to move it. Well, then I could put the pads and use TENS to run it through their knee, maybe on each side or on one on top of the patella and one on the bottom, down towards the tibia, or one behind in the calf, and try to run it straight through the knee to decrease the pain. So you could use TENS there. Or what I would probably do is use NMES, neuromuscular electrical stimulation, to try to get those quads to contract and see if contracting those quads decrease their pain. So I'd probably still stay with the muscle strengthening there or the muscle facilitation. But if they're able to straighten it themselves, then you don't need to do muscle facilitation. Maybe it's more a matter of pain. So let's look at this. Right? Hopefully this makes it a little bit easier. This is, again, one of the questions that we looked at. You'll see that in the clinical practice guidelines and other ones, like with people with patellofemoral pain syndrome, it'll specifically say, do not target the vastus medialis. So one of the recommendations of our clinical practice guidelines with patellofemoral pain is do not target the vastus medialis, because you really can't do that. You need to target the whole quads. That's the real point. It's not just the vastus medialis. But after this, hopefully it makes NMES a little bit easier of a choice. Now, tissue repair. This can be a little bit harder. Okay, we've got high volt pulsed current, and we're going to talk about infected and injury potential. So in general, okay, so these are kind of the recommendations. The negative is used for treatment of infected or inflamed wounds and cellular activation of the neutrophils and microfibroblasts. So that's why it's really used in that initial stage. And then also, if you're activating those fibroblasts, all right, that's going to be used in terms of, activating collagen, bringing in myofibroblasts, those types of things. So in the early stages of wound healing, if there's inflammation, negative is often used. And it's also used in the proliferation phase. So it's also used in the proliferation phase. The anode, or the positive, okay, is really primarily only used with epithelialization. So you're like, whoa, I can't remember all those things. Well, okay. So here's what you got to remember, is that the anode, the positive pole, all right. Yeah, so I'll get into that. I'll get into that question in a second. So epithelialization, that's when the anode is typically used, okay? So that's when the anode is typically used, unless silver is being used, all right? So unless silver is being used, and that's when the anode is also used. Now, brief intense TENS, you really, the only time it might be used, and you'll see some people talk about it with wound care is with before you debride. So you're trying to get a big, intense period of analgesia right before you debride. So that's a great question. That's the time you might see brief, intense TENS used. So I'm just going to kind of go over this because it's a little confusing. And again, I wouldn't try to memorize all this. This is just how it's done. All right. So what they're using is usually using a monophasic pulsed current. Now, that is often called high volt pulsed current. So a high volt pulsed current is one form of a monophasic pulsed current. And so what you're getting is a polarity difference. So like this electrode might be negative, and then the other one, the other pad, would be positive, basically. And so you have a polarity difference. And what you're trying to do is, again, mimic that injury potential, right? I don't think this is the best technique that they're using, but it's the example I have. And then I wouldn't try to memorize pulses per second, pulse duration, because there's a variety. There's not one uniform, this is the way you do it. Okay, so that's the good news. You don't have to sit there and memorize the pulses per second, pulse duration on that. How often should it be used? That's up for speculation. It can be used daily. It can be used twice a day. So BID, sometimes people are not familiar with that acronym anymore, but that's twice a day. And so that's the recommendation. There is a ton of evidence behind it. Medicare pays for it. There's just a lot of evidence for wound healing with electrical stimulation, but you shouldn't be using it right away. So if you got a wound that's not healing, right, within 10, 14 days, maybe it's time to use e-stim, but you wouldn't use it on an acute wound. So that's a pulsed current. Now, you can also use direct current. So it's used in the exact same way, okay, and for the exact same reasons. So the negative and the positive, the reason why you use them are exactly the same. So again, negative is what you primarily use if it's infected or you're trying to promote fibroplasia. If you're trying to promote epidermal healing, it's the anode. All right. So that doesn't change. All right. That's the nice thing. So high volt or direct current works. Now, direct current, there's the potential to burn somebody. So that's the one that's a little bit more dangerous. So if I was going to choose one, so monophasic is used for tissue healing. Monophasic for edema, there's not evidence out there to use e-stim for edema management in terms of moving like protons and stuff like that, and that it actually decreases edema. What's recommended if you're trying to decrease edema is muscle contractions. So it's going to be compression and muscle contractions, and you can cause muscle contractions with electrical stimulation, but if you can do it volitionally, there's no reason to do it. So that's really it with that in terms of that. There's a whole lot of protocols out there. That's not what you need to focus on. All right. And then we'll come back to it. So again, these are the parameters that are important. These are kind of the summary of the recommendations of what you use over it. And then you're using a pulsed current, which is usually called high volt pulsed current. All right. Or you're using direct current. And then the really parameters for when you choose the negative and the positive over the wound don't change. So I'm going to briefly speak about iontophoresis because it uses direct current. So iontophoresis, one of the things it does is it uses direct current to try to push medication into the skin. All right, and it's based on the principles that light charges repel. All right, and so that's the principle it's based on. And so again, what you see in this little graph here is there's a pad, there'll be medication in it. And so you see the positive pole up there, okay? and it's driving the positive medication into that area of concentration. Now, it does not penetrate very deep, so this would not be used for deep structures. So I'm going to let you answer this question real quick and see how you do with it. Okay, I'm going to start to talk about this one, but a patient is having iontophoresis treatment for a painful shoulder. Sodium salicylate is the medicinal substance that is being administered. Which method of treatment should be utilized? And so a couple things. If you don't know anything about iontophoresis, this becomes hard. If you know a little bit and you know it uses a direct current, then you're going to eliminate 1 and 2 really quick. So the real key words here is, are iontophoresis, that's what you're using, and sodium salicylate. Now, interrupted monophasic current is a pulsed current, and that's not what you want to use. That's the active electrode. And then it's a matter of knowing, well, what is the polarity of sodium salicylate? So there's some drugs you don't need to know a ton, but it is negative. Now, I don't know if that helps any of you, all right? But if it's negative, that means you put it under the like pole, which is the cathode. So the cathode is the correct answer, number 3. So remember, the cathode is the negative portion of the circuit. Don't confuse that with cations, all right? And so a couple things. So continuous monophasic current, all right, with the cathode as the active electrode. Somebody asked about what medications should you focus on. Well, I'll tell you in just a second, all right? So now you know, if you know about the current, the type of current, that helps you make a choice. And then if you know about the medication, then that helps you make a choice. So what do you need to know? Okay, so this is kind of what I would know. And I really wouldn't, all of these are not important, all right? So here's my suggestion to you, is not to sit there and focus on a lot of medications, all right? That's not what I would do, all right? So yes, I'll go over the cathode again. So a couple things. So if you can remember this, I said C, all right? Those are all negative. Iodine, salicylates, acetic acid, dexamethasone, and then your chlorides, right? Those are all negative. I said C. And so then what are the other ones we use? Positive. So I don't even have to sit there and memorize the other ones, right? I wouldn't memorize magnesium, baclofen, lithium, zinc. Well, I did talk about that with wound care. Copper. What we usually use with iontophoresis on the positive is hydrocortisone and lidocaine, and both of those are positive. But if you know your negatives, then you know the positives. All right. So you really only have to know half. Whichever half you choose to know, that's fine. Then you know the other ones are the opposite of that. So why does that work? Okay, so the cathode is the negative polarity of the circuit. Cations are positive, and that's why they're attracted to the cathode. So the cathode is negative, and the anode is positive. And when you talk about cathode and anode, those are referring to the circuits, not the ions. Okay, so that's talking about the polarity of the circuit, not the ions. So cathode is negative and anode is positive. Hopefully that helps. So dosage, I wouldn't sit there and try to memorize dosages or anything like that. That's not important, but It is recorded in milliamp minutes. I don't know if they would ask you that, but that's typically the way it's recorded. And that's just how many milliamps per minute occur over a period of time. So 40 milliamp minutes is the typical dosage most people start out with. And you could achieve that in a variety of ways. It could be 1 milliamp for 40 minutes. It could be 2 milliamps for 20 minutes. It could be 4 milliamps for 10 minutes. And that would be all the same dosage. Right? Which is best? Don't know. Doesn't really matter. Okay? They all deliver the same dosage. It's just different ways of doing it. Now, precautions for ionophoresis, it's going to be the same precautions as for all electrical appliances. The other thing that you see also is you probably shouldn't use it after other physical agents because there's altered skin physiology. All right. And again, if you're applying a medication, you need a prescription. And just like any other electrical modality, you always check the skin integrity. And then you really want to check post-application, the integumentary and documentation, because it is a continuous current and there is the potential for a burn. And so you always want to check afterwards and make sure there's not. If there is, then you document and treat appropriately. So we're closing in on the end. I hope this has helped you understand a little bit. We're back at the start about different types of current, direct current versus pulsed current. Again, we didn't spend much really talk about alternating current, but it can be used for pain just like you would do with pulsed current. I hope this has helped you understand a little bit about the primary areas we use E-stim for pain management, muscle dysfunction, and tissue repair. And then contraindications. Whenever you're applying any type of modality, you need to know your contraindications and your precautions. Because again, this NPTE is about safety. There's only a few questions over therapeutic modalities. E-stim is something that could be part of that. And that's why we covered that tonight. So we have just a few minutes left, so I'll kind of leave it open to questions. I'll remind you next week, July 17th, Dr. Thomas Sutliff will present on disorders of the elbow, forearm, wrist, and hand. If you've never heard him lecture, he is wonderful. Anatomist and just truly a great educator. So again, the next week will be Dr. Sutliff and talking about disorders of the elbow, forearm, wrist, and hand, again at 7 p.m. Eastern Time. And just to be respectful of our time, I'll see if there's any questions. Well, I appreciate the questions you've shared. Oh, there's one there. All right, well, thank you. Well, if that's it, I'm going to go ahead and conclude this session and let you get on with your evening. Thank you for your attention, and I really appreciate it, and I hope this is helpful. My name's Vince Lepak. I'm one of the therapy ed instructors. Thank you.